Hello, hello again. I will talk about the pathophysiology of intracerebral hemorrhage. Intracerebral hemorrhage is known as hemorrhagic stroke, which is a sudden bleeding into tissue of the brain, ventricles, or into pores. It's life-threatening and requires quick treatment for the best outcome. There are many types of brain bleeding. It's called epidural bleeding between skull bone and the outmost membrane layer dura mater. Subdural between the dura and arachnoid, and subarachnoid, which is between arachnoid and the pia mater. Types of brain hemorrhage, as we mentioned before, and there are two types of brain bleeds that occur inside the brain tissue itself, which intracerebral hemorrhage and intraventricular hemorrhage. What is etiology and pathophysiology? Is there a difference between etiology and pathophysiology? Yes. Etiology is a term used to define the cause of any disease, while pathology it depends to define what the change later occur later on. So the change that are observed. Physiology referring to the functional process or mechanisms that occur during a disease process. Basic type of intracerebral hemorrhage as the etiology, hypertensive hemorrhage, arteriovenous malformation, and amyloid angiopathy. Hypertensive due to chronic high blood pressure, arteriovenous by congenital defect, and amyloid angiopathy is caused weakening of blood vessel due to aging. Hypertensive microangiopathy, chronic standing arterial blood pressure causes vascular remolding as accelerated, resulting in lipohydrosis and through architectural dissection, which rupture and has allowed high pressure extravasation of blood into the deep parenchyma. Cerebral amyloid angiopathy is an age-related disease, as mentioned before, where amyloid builds up within the arterial wall, resulting in loss of smooth muscle skill and significantly increase the risk for deeper intracerebral hemorrhage. The result in fibrinoid necrosis and weakening of the vessel wall with ultimate rupture into brain parenchyma. A familiar form of cerebral amyloid angiopathy occurs earlier in life and is caused by mutation in the amyloid precursor protein gene. That means it's not mandatory occur in old age, but it can occur early life but due to mutation in the amyloid precursor protein gene. Coagulopathy, anticoagulant, and antiplatelet medication, which are used to multiple hemorrhage or caused multiple hemorrhagic or vascular disorder, neuroregeneration direct acting anticoagulant agent are lower risk than that seen with already old anticoagulant. Coagulopathy is associated with congenital mostly or acquired liver failure, diffuse intravascular coagulopathy, thrombosis, and factor deficiency can cause an exacerbated intracerebral hemorrhage. COVID-19 can lead to endothelial dysfunction and therefore leading to intracerebral hemorrhage. There are some drugs which potentiate or facilitate or increase the possibility of intracerebral hemorrhage, such as sympathomimetic agents such as amphetamine and phenylalanine and appetite suppressant and other drugs using for cough medication increase the risk of intracerebral hemorrhage. It is believed that transient supraphysiological increase in blood pressure lead to vessel rupture due to these drugs. Cocaine has also implicated in causing aneurysmal arteriopathy. There are other risk factors, several vascular lesions associated with an increase. They are referred as secondary intracerebral hemorrhage. The famous one is the cavernous angioma disease, is an autosomal dominant in neurovascular disorder characterized by endothelial cells dysfunction and dysregulation of neurovascular unit architectures. Moyamoya disease, which is the famous and is a rare abnormal hyperplasia of smooth muscle cells and luminal thrombosis in arteries within the basal ganglia. Arteriovenous malformation cause bleeding from high flow arteriovenous shunting, gradually weakening arterial feeder and vessels and arterized vein. Aneurysm are dilatation of blood vessels caused by weakening of blood-brain barrier angioarchitecture. Aneurysm rupture, primary cause subarachnoid hemorrhage. Mechanism of injury and therapeutic target. The initial bleed cause this physical disruption of cellular architecture of the brain and the mass of the hematoma. So there are two causes or two pathology: hematoma or disorder or disruption of cellular architecture of the brain. And this is hematoma increase intracranial pressure, which can compress brain region, potentially impeding blood flow and leading to brain ischemia. So, due to hematoma, lead to increase intracranial pressure, lead to occlusion of the vessels or remote vessels, leading to stroke. So, there are some cases intracerebral leading to ischemic stroke. Broadly, secondary injury after intracerebral may be caused by a cascade of events initiated by the primary injury, mass effect, physical disruption, by the body tissue response to the hematoma, and, for example, inflammation, and release of clot component, hemoglobin ion. Due to loss of oxygen carrying hemoglobin and effective circulating vascular volume, massive hematoma lead to a marked increase in carbon dioxide and carbon monoxide and thus a marked decline in oxygen. As a result, oxygen demand exceed oxygen delivery, leading to a state of anaerobic metabolism and lactic acidosis. Lactic acidosis may significantly impair the coagulation system, leading to a hypocoagulability disorder. So this is a sequence mechanism. Sequence mechanism mean due to hemorrhage, oxygen demand exceed. There is a state of anaerobic metabolism, lactic acid, lactic acidosis leading to a hypocoagulability disorder. And this is cartoon in that or feeling that what is the mechanism? All of this hemorrhage, hematoma, blood-brain barrier breakdown, vasogenic edema, and peripheral edema, perihematoma edema, hemoglobin breakdown, and oxidative stress leading to apoptosis. There is another type of inflammation which is called traumatic brain injury. It is called second injury, and two main mechanisms that cause primary injury: direct struck or direct striking into the skull, or in vehicles acceleration and declaration result from unrestricted movement of the head and lead to shear tensors and compressive strains. Additional medical complication: acute seizures with the first 24 to 72 hours with incidence 4% and 42%, and even higher incidence when including electrographic seizures without clinical duration. Seizures are associated with deeper location of hemorrhage, presence of subarachnoid hemorrhage, subdural hemorrhage, and complication including deep bleeding. Fever is common in the first 74 hours of patient and is commonly seen in patients with intraventricular hemorrhage. Hyperglycemia is also frequently observed in the first 72 hours. Hyperglycemia during the time period is independently associated with worse outcome. There is another item which is called is immune response on intracerebral hemorrhage in response to cerebrovascular injury after intracerebral. Monocyte emerges as a critical component in the peripheral white blood vessels. After intracerebral hemorrhage, the infiltration of white blood cells peak within 1 to 3 days and can persist for weeks. Monocyte and macrophage play a dual role not only in the initiating threat response but also in contributing to the brain tissue repair. So the immune response has a dual action, maybe as a protective or otherwise is an autosis. And this is cartoon present the immune response, brain edema, and the several hemorrhage linked to brain edema and inflammation, coronal damage, oxidative stress, brain recovery. Immune response through underlying dispersity and evolution of these cells in the pathology, including their cellular marker, function, and apoptorization state, may offer new insight for developing specific treatment of all patients with intracerebral hemorrhage. Brain recovery after intracerebral hemorrhage. If patient survives the initial days after intracerebral hemorrhage, there is a gradual root results. Patient may recover from neurological function, although this recovery is almost always incomplete. The improvement of function may involve root resolution, subsides of acute injury, reduced edema, neuronal plasticity with surviving neuron, including the contralateral hemisphere, taking on and possibly neurogenesis. Management, first, we need to neuroimaging CT scan is highly important in detection of the early bleeding, but the CT scan allow accurate estimation of intracerebral volume and grading the extent of intraventricular hemorrhage, such as intracerebral hemorrhage. Magnetic resonance imaging allow better imaging of hematoma evolving over time, so it is as a follow-up and is more sensitive than CT scan in detecting underlying tumor. That means if the hemorrhage into tumor in situ, the MRI is more sensitive than CT scan tumor. And also allow the grading of extent of associated ischemic cerebrovascular disease, multiple white matter hyperintensity, and cerebral microbleed marker of cerebral small vessel disease. There is no single treatment has been shown to significantly improve neurological intracerebral hemorrhage management. Guideline focus on prevent type of intracerebral risk factors management, medical treatment to prevent worsening following initial hemorrhage, and consideration of surgical management for certain patients. Prevention, primary and secondary prevention through appropriate management of modifiable risk factors for that the best hypertension, strict management of blood pressure, anti-thrombotic management with sequelae of ischemia on top of intracerebral hemorrhage. Seizure management, several study findings a benefit for prophylaxis treatment of with anti-seizures, which is called anti-epileptogenesis for few weeks. Intracerebral, intracranial pressure management, standard medical management including elevation of the head, sedation, brief of hyperventilation, and use hypotonic magnitude and hypertonic saline. This is a cartoon which lead to the schema of initial and the management. Thank you.